Right, so we are going to discuss the topic of insomnia. So basically it's targeted to pharmacists as well as other healthcare practitioners. So it's going to be just a discussion-based presentation. So anytime you guys have any questions, just let me know, and we can definitely stop it at any point. So this is just a question that pharmacists especially hear a lot in practice. So, I just have a quick question. What is the best thing I can take for sleep? I think we all know this isn't really an easy question to answer because there's a lot of things that go into what leads to sleep deprivation or issues with sleep. So for the learning objectives, we're going to understand the definition of insomnia and describe the key terms related to this condition. We're also going to recognize the importance of insomnia as a primary healthcare concern. We'll be able to identify medical conditions and medications that may mask insomnia. And given a patient scenario, we will be able to construct questions to identify sleep patterns and other factors that may mask insomnia. And we'll be able to summarize non-pharm and pharm treatments for insomnia. And given a patient case, we'll discuss appropriate treatment plan. And then we'll be able to recognize patients in the community pharmacy setting who may benefit from benzodiazepine prescribing and develop a plan. All right, so what is insomnia? So basically it's problems getting to sleep, staying asleep, or early morning wakening. And this is defined as more than 3 nights a week for more than 3 months. So basically this is despite the adequate opportunity for sleep. So for instance, if we have a new mom like Jessica who's had a baby recently and she's having problems with obviously getting and staying asleep, or having restlessness during the day, that's because of something else going on in their life. So this is despite the ability to be able to sleep. This is not attributed to substances and not explained by sleep-wake disorders. So sleep-wake disorders include sleep apnea, restless leg syndrome, narcolepsy, or other medical conditions. So this is not related to those. So prevalence. Basically, it is approximately 1/3 of the general population, which is quite a lot of people. It is higher in women as well as the elderly population, and single parents as well as people with lower socioeconomic status seem to suffer from insomnia. What is the impact of insomnia, or why is it important? So this is a primary healthcare concern because it can lead to sleeping or napping during the day, which can decrease our productivity at work or lead to absenteeism, or lead to issues with mood, so people might be more irritable, might have limited cognitive function at work due to lack of sleep. And it can also exacerbate other health conditions as well. So for instance, psychiatric disorders, especially depression, as well as substance abuse disorder, it can exacerbate. Can also worsen hypertension as well as migraine disorders. So we're going to move on to conditions that can mask insomnia. So for mood disorders, like anxiety or depression, can often mask insomnia. Same thing with thyroid disease, as well as menopause. So actually over 80% of peri and postmenopausal women with hot flashes experience insomnia. So that is something to consider. Your mom, yeah, for sure. Yeah, she has bad insomnia. Also doesn't help with the online booking of trips.
Yeah, no.
Gastrointestinal disease is also another condition, as well as heart disease, pain, caffeine use, and recreational drug use as well. So medication that can mask insomnia. So stimulants. Does anyone have an idea of stimulants that can mask insomnia that you can think of? Yeah, caffeine's a big one. For sure, especially if you're drinking it late into the day. Obviously, students use that to their advantage to be able to stay up late. Any medication that you can think of? Yeah.
Boom.
Yeah. Anything that can...
Cocaine.
Yeah. I don't know if that's a prescription medication, but...
Maybe nicotine.
Yeah, nicotine's a big one. Yeah, for sure. Yeah. So like serotonin modulators for sure can actually impact REM sleep. So for sure. And so Synthroid, corticosteroids, so opioid sedatives. So opioids and sedatives seem a little bit opposite. You think that these would cause drowsiness. So does anyone have any idea of why they might actually lead to insomnia?
Guessing they disrupt circadian rhythm.
Yeah, they can do that, and also you can get dependence. Basically, your body becomes dependent on it for sleep over time. So if you aren't taking it, or if you're not on the sustained release, then your sleep can be disrupted or can be dependent on it for sleep. And yeah, that's most of the medications. So lifestyle factors that can contribute to insomnia. Shift work is a big thing. Obviously, Catherine, you know this. So people that are shift workers often have a really hard time getting back on track for the regular schedule. Travelers, jet lag, parents with young children. Jessica?
I get all these things.
You get all these things, yeah. Non-ideal living situations. So people who are in lower socioeconomic status or people who don't have, proper living conditions may also suffer with this as well. System still? Yeah. So this is our patient. Hilda, she's a 43-year-old female. She comes to the pharmacy looking for a sleep aid and wants to know the best thing that she can take. This is a very common question that we get in the pharmacy. So based on this, what would you ask Hilda? She comes to you as a physician or a pharmacist, and she wants to know what the best thing is. What would you ask her? What kind of questions?
Probably ask her what she's tried so far.
Yeah.
Definitely. Getting to sleep, staying asleep.
Yeah. Yeah,
Like a
so
sleep history.
Yeah, sleep latency is a problem with staying asleep for sure.
How long?
How long has it been going on for sure?
The sleep hygiene history.
Sleep hygiene.
Mm-hmm. Yeah. So what kind of her sleep patterns are like?
Past medical history.
Yeah.
Stressors.
Yeah.
And her
Good one,
medications would be important for sure.
Definitely.
Any allergies for the
Yeah.
recommendation?
You guys nailed all of them pretty much, I'd say. So basically open-ended questions are really useful because you get more information if you ask open-ended questions for patients. So exactly how long has it been going on, how many days a week, you get a bit more insight into how much it's affecting their life. Pretty much exactly what you guys said. What have you tried, what the history is. So our friend Hilda, she's been experiencing symptoms 3 to 4 times a week for the last 3 months. So based on this, would you say this would be considered insomnia? Do you guys remember a definition? Yeah, so more than 3 times a week and more than 3 months. So she would be considered a patient who's experiencing insomnia. So she mostly complains of problems getting to sleep, but often awakens during the night. And she also complains of not feeling rested during the day. Her medical conditions include GERD and hypothyroidism. Her medications are pantoprazole, 40 milligrams once a day, Synthroid, 150 micrograms once a day. She also takes a calcium and vitamin D supplement. So based on this information, do you have any follow-up questions for Hilda?
Mm-hmm.
Yeah.
Your levels have been checked for the thyroid.
Exactly. Yeah. So those are all good questions to ask her. So she, like you said, Jessica, definitely important to get the thyroid level checked because we all know that that has a contribution in the sleep-wake cycle. So she says her GERD, another question obviously would be, is your GERD related to your insomnia? Are you finding that you're waking up in the night with symptoms, that sort of thing? If so, do you do anything to help manage that sort of thing? But she actually has very well-controlled GERD. The last time she actually had her thyroid checked was 1 year ago, and her levels were normal. Her doctor gave her a requisition for blood work, but she did not think it was necessary since she's been on the same dose for 5 years. Why would she need to get a dose change?
Come on. A lot of compliance.
So, as you think about the case more, we can move into treatment options. We'll talk a little bit more about treatment options for insomnia. So basically, for managing any type of sleep disorder, really, you want to rule out and treat any potential medical conditions that the patient may have. We'll go into a little bit about non-pharm recommendations as well as OTC and prescription medications. So for non-pharm, cognitive behavioral therapy really involves a multitude of different types of things. So it involves stimulus control therapy. So the big thing is, avoiding screens, 1 to 2 hours before bedtime. This is like a huge thing, especially nowadays where everyone's got a cell phone or an iPad or computer. If you can, even the Kobos, like the light up books, can actually mess a little bit with the melatonin in the body too, so it can mess with the circadian rhythm. Avoiding naps, waking up and going to bed at the same time, trying to get a good sleep pattern, leaving the bedtime for sleep and intimacy only. So avoid, if it's a student who's spending a lot of time in bed, that can kind of create that, being able to study somewhere else can create that disassociation from sleep versus studying. Doing relaxation techniques. Nowadays, there's a lot more apps, like the, what's it called? Headspace is a big one that a lot of our patients tend to be using now, which seems to be really effective for people. As well as, sleep hygiene, so getting some exercise, usually like earlier in the day before supper time, if possible. Avoiding alcohol and caffeine stimulants, cool dark room, trying to get blackout blinds, preventing the light from disrupting the sleep is the big thing. So talk a little bit about non-prescription medications. Benadryl or diphenhydramine is a common medication that's marketed in our over-the-counter aisle. Basically, it's not ideal, especially for the elderly and those on other sedating agents. I remember I had a pharmacy professor in school who called this, he said the Remillard rule is to never use a side effect of a medication to treat another condition. So basically, an antihistamine using the drowsiness to treat insomnia is just a bad idea altogether. So it's just messy. Basically, if people have been using this for long term, you definitely want to recommend gradually discontinuing it because it's not, basically, eventually it's going to affect their sleep patterns long term. Tryptophan, there's limited safety evidence on it. It has issues with serotonin as well, has risks of serotonin syndrome. Melatonin, there's some evidence for it, and its risk is very minimal, so it's worth a try for sure. It may improve sleep latency, but may not actually help you stay asleep. So it's good for like jet lag or shift workers. May restore the circadian rhythm, so definitely worth a try. Valerian, limited evidence. You see this a lot in like natural health product stores. It's been linked to issues with hepatotoxicity, so I don't normally recommend it. And it's not safe in pregnancy either.
For Benadryl, I thought there was you almost develop a resistance to it after using
Yeah,
it
you
for
do.
a few days.
Yeah.
Tachyphylaxis
Very
or
similar.
Only good for 3 days.
Yeah, very
then it just doesn't
similar
work anymore.
to benzos. Yeah.
But if you took a few days off,
And
then
you can
start,
Yeah.
Yeah.
So that's why they say like rule of thumb, no more than 4 days in a week.
Okay.
Because if you do use it consistently after 3 or 4 days,
3 days.
3 days,
but
yeah,
you
then you
use it
start to get-
effectively for 3 days.
start to
Yeah.
get tolerance for it.
Right.
And the sneaky thing about Benadryl is that they put it in a lot of like the sleep ease and like things that are marketed for sleep. So patients will be like, oh, like this is for sleep. It's not for allergies, but it is for allergies.
Yeah.
They just market it for sleep.
Like, it still could be useful for some people. Like, I'd still give it to someone for like very specific things. Like,
Yeah.
I'm,
Yeah, and I mean, if you're
That's
I
traveling,
need a flight. I'm taking
yeah.
an overnight flight, and I want to
Yeah.
sleep or something. There are some
definitely,
times.
yeah, as long as it's not for risk of you overusing it,
Yeah.
definitely.
The
Yeah.
valerian, it actually interacts with, I didn't know this until last week when a patient called, said that they were taking valerian and they were on 2 different benzos. So they shouldn't have even been on 2
Oh my
benzos,
gosh.
but it actually increases the level of the benzodiazepine.
I
And
didn't
they
know
have,
this.
they have,
Oh.
and there were a few case studies to show that people actually stop breathing in their sleep because of the amount of benzotoxicity from the valerian. So
Wow,
I didn't know this until like a week ago.
that is crazy. I didn't
Yeah.
know that either. That's really interesting.
Another
But-
fun fact about valerian. Cats love it.
Really?
And it gives us pretty wicked dreams.
Really?
Yeah.
Cats love it. How do you
Cats
know this?
love it.
Gives you wicked dreams.
Yeah.
That's amazing.
I've not tested that in my cat.
Yeah.
Does it give your cat wicked dreams?
Oh.
Okay, so back to our patient. Based on what we went over, what happened, Mike? Can you fix that?
Yeah.
So based on what we went over, what would you first recommend for Hilda? So she's gonna go get her levels checked. She's gonna get that all sorted out. But in the meantime, she really needs something for sleep.
CBT.
Yeah, for sure.
Yeah, and you can review the sleep hygiene and stuff.
For sure.
She can
Yeah,
try
sleep
some of those
hygiene is a
techniques.
big thing. How about Any like non-prescription medication, would you recommend anything for her for that?
Benadryl.
Yeah, she could try it if it's just a short-term thing. But yeah, like Jessica said, if she's at risk for the person who would overuse, then it may be a better idea to use melatonin because of its safety profile. Yeah, CBTs is definitely a big thing. So we're going to go over a bit of prescription medications. So benzodiazepines is very commonly used, especially in Newfoundland. It does have its place. That being said, it does have high risk and falls in the elderly, as well as risk of dependence. So the medications that are indicated in Canada are flurazepam, nitrazepam, temazepam, and trazlam, although there are other benzos that are used for sleep. Flurazepam and nitrazepam are definitely not recommended. This is because they do have a long half-life. So basically, if you are using them every day, it can lead to accumulation, which can lead to risk and falls, especially in elderly people, and can lead to like the hangover effects, which we don't really like. Trazlam has a quick onset of action, but basically it has a short duration, which can increase its risk of abuse.
It's got a bad rap as a day rape drug.
So of these, temazepam is the most recommended for sleep. That being said, it doesn't have very high potency, so some people don't like to use it for sleep. Often, lorazepam is very more frequently used than temazepam in certain settings. Oxazepam may be as effective as the other agents that are listed for Canada. That being said, it has a very slow absorption rate, so it does take about 60 to 90 minutes to really start working, which people might not find useful for sleep latency unless they can time it out properly, but that's why it's often not used for sleep purposes. So for benzodiazepine use, we want to limit their use to 3 to 4 weeks of continuous use for insomnia because it can alter sleep stages and it also loses efficacy over time. It can also lead to dependence and risk of falls, that sort of thing as well. So for benzodiazepine receptor agonists, these include zolpidem and zolpidem. Similar efficacy to benzodiazepines. They're gaining more recognition now because they do offer less dependence compared to benzodiazepines. That being said, people do still become dependent on them. But they do also have their side effects as well. So make sure that we do counsel patients on avoiding alcohol and driving for 12 hours even after the administration of these medications because they can affect driving and cognition. So next, we're going to talk about off-label use. So we often see, antipsychotics like quetiapine, antidepressants, trazodone, mirtazapine, amitriptyline. Not normally recommended to use this solely for insomnia. The reason for that is because they affect other neurotransmitters as well. They are useful if someone already experiences the symptoms related to depression or psychosis, that sort of thing. You can kind of take advantage of that side effect profile, but they should not be used solely for insomnia. But they are. But they definitely are, for sure. So back to our patient case. So Hilda comes back. Her TSH levels were too low, so her doctor actually decreased her dose to 125, and her levels returned to normal. 3 months later, she returns to the pharmacy. She's still experiencing problems getting to sleep 2 times a week and is waking up unrested. She's already tried the melatonin, didn't work. Based on the options previously discussed, so is there any prescription options that you may recommend for Hilda? Do you think she might benefit from a benzodiazepine or a benzodiazepine receptor agonist?
I mean, you could certainly trial one of those.
Mm-hmm. Yeah.
Assuming she's addressed all the other things we talked about before. It sounds like she's addressed the medical side of things, like the TSH thyroid issue. But I mean, you could trial one of the benzos for even 3 or 4 weeks and see if she gets some improvement, and then reassess her other techniques
sure.
right at that point.
Yep.
Depending on how she responds.
You probably wouldn't though. Kind of last resort.
Yeah.
I feel like.
Yeah, and it depends on the patient too. So I mean, if she has, if it affects her daily life, and I mean, if she really needs to get that sleep in, then it might be worth a try.
Yeah.
probably zopiclone might be
Yeah.
one of the better ones to try
Yeah.
because of its less risk of abuse. But yeah, like you said, it does depend on the patient. So I mean, it's hard. It's a double-edged
not
sword
perfect.
because a lot of people do get, stuck on even zopiclone forever and ever and ever, never got off of it. So as long as you kind of reinforce it's just an as-needed medication, then I think it could be an option for her, assuming that she's addressed all the other issues.
And you probably want to screen her for like mental health reasons that she's feeling this way.
Yeah, definitely. And
She's depressed
like
or
you said,
something.
make sure that you reinforce all the sleep hygiene stuff as well. Okay, so we'll talk a little bit about deprescribing benzos. So I added this. What time are we at now? Okay. I added this topic in here because pharmacists and physicians also will be having a larger role in deprescribing. The benzo taper may be a difficult topic to address. People love their benzos, let's be real. And but it is a very difficult thing to address, but it is very useful for preventing falls, preventing cognition issues, daytime drowsiness, that sort of thing. So patients who are tapering these agents are very likely to experience insomnia, so that's why it's good for us to step in and kind of coach them through it and how to get off of the benzos. So here I'll discuss a little bit about the recommendations on when and how to deprescribe benzos. So right now, we're more so targeting elderly patients, so the people who are at highest risk for benzo use. They've been using benzos for longer than 4 weeks to treat insomnia. These guidelines do not, so these are from the deprescribing guidelines. They do not yet involve people using benzos for psychiatric conditions. So people who legitimately need this for anxiety, other issues, seizures, like we don't address this yet. This is just strictly for insomnia. So a slow taper is recommended to decrease the risk of withdrawal. So withdrawal symptoms are agitation, obviously insomnia, gastrointestinal issues, that sort of thing. Usually we recommend a very slow, 25% reduction every 2 weeks.
That's what you learned. 50. Come down
It was
half.
pretty
Just
slow.
a 50.
Like
Yeah.
50 for the
Generally it
first
takes
and
like
then
3
slow.
These are the new guidelines that suggest you can do it this way. That being said, they say you can go faster
Gotcha.
if they have higher
I
risk.
did clonazepam today at like
Yeah.
50%.
Yeah.
But
And
It also depends on the half-life.
And clonazepam does have a
That's a
longer
longer
half-life for sure. So I think for something like lorazepam, you might be able to get away, or like Trazlon, you might be able to get away with.
Maybe
With
for insomnia too.
Yeah.
Different.
Very different
Exactly,
game
yeah.
for if it's a psychiatric issue. Like for anxiety, it might be a completely different
Do
thing.
you guys
too.
use deprescribing.org? Have you?
No, I've
That's a,
See,
it's,
I've heard.
I've
yeah.
it's a
seen
great
it
tool,
for
and
PIs.
so they used to just have benzos and antipsychotics, and now they're adding
PPIs.
PPIs. They're adding ADHD medications. They're adding
Antidepressants, like
antidepressants.
SSRIs.
They're on there already. Yeah,
Yeah.
it's excellent. And but yeah, their guidelines are a little slower than 25% every 2 weeks. It's usually 25 every 4 weeks.
Yeah.
I'm
Wow.
pretty sure, and that's for both insomnia and anxiety.
Yeah.
But
And I think part of it is because, well, Newfoundland is starting to incorporate these guidelines a little bit now,
sure.
and
Yeah.
people are really, really hesitant. Like
Yeah,
people do
yeah.
not want to give up their benzos.
I think a lot of people too are afraid of like the seizure risk too.
Yeah.
Like
Yeah, if you're
Yeah.
hospitalized, it's different.
It's
Obviously.
hospitalized
yeah.
for like
Yeah.
anxiety stuff, and
Right.
she has seizures, which is
Right.
which
Yeah,
is
side
everything.
so I can see a quicker taper in a hospital for sure, but
where they're a bit more
in
And
the
she
monitored.
wants off
community.
everything.
And I think
Benzos
it's
cause
completely up to the
seizure?
patient too.
No.
Like if they want to get off of it, like
Sure.
if they have the
Sure.
motivation, then you might be able to get away
That's
with
true.
doing a faster taper because
Yeah.
they might be aware of some of the withdrawal symptoms. They might be more willing to deal with it. But if you have an older person who's really like combative and wants to stay on their benzo, then of course you might want to take it a little bit more like
Depends on
slower.
how long they've
Yeah,
gone to.
depends on the patient. So yeah, basically if they have a higher fall risk, you want to get them off sooner. But if they are a bit lower risk and they're really, they want to keep their benzo, then you might want to go, yeah. And then basically near the end of the taper, they even say decreasing by 12.5%. So really, really slow at the end because as you get to that last, they say 25% of the original dose, then it's a lot harder to get them off. It's no longer, they used to recommend switching to a long agent to prevent the withdrawal, but they actually don't recommend doing that anymore because it hasn't shown evidence to actually reducing withdrawal symptoms, so they stopped recommending that. So close monitoring and support is highly recommended. So as pharmacists and especially family doctors, we have a big role in doing that. So we want to let the patient know that these, insomnia or any other withdrawal symptoms can occur, and they will be short term, they will go away, but if they're unbearable, then just let us know, we can kind of help them through that. So they actually do recommend clinicians monitoring every 1 to 2 weeks for efficacy, so cognition improvement, stability improvements, that sort of thing, as well as withdrawal. So agitation, irritability, sweating, GI issues, that sort of thing. Anyone have any more comments on benzo prescribing? So basically, for the conclusion, insomnia can be debilitating for some people, and managing the condition, can improve their overall quality of life. So us as healthcare practitioners have a big role in helping patients with this. There are many medical conditions and medications that can mask insomnia. Non-pharm therapy is first line and should always be combined with other treatments. There's a lack of evidence for most OTC and herbal products. Melatonin may be useful for sleep latency and jet lag, especially due to its low side effect profile. First line prescription agents involve benzos or benzodiazepine receptor agonists. Now research is a little bit gearing more towards the benzo receptor agonist because of its lower cause of dependence. Off-label medication may be appropriate if they're treating another condition, but not if they're treating insomnia alone. So kind of circling back to our original question, what's the best thing that I can take for sleep? So obviously this is a very complex question. It's not as simple as it might seem. So basically the selected agent depends on the individual. So it depends on, their history, what they've tried before, what their stressors are, that sort of thing. So we have to get more insight into that. And I hope that you guys can take what you learned today into your own practice. Does anyone have any questions? No? All right. Thank you for attending.